Health to talk about where we're at with COVID and living with COVID. So first I want to talk a little bit about our numbers because people can get these on the website. You've probably heard that here in Forsyth County now we've had the past 2 days with 50 cases per day. And not to just pick on Forsyth, but Guilford's numbers are up a little bit. And then some places that are a little bit more surprising, smaller populated areas. Davidson, Randolph, even Yadkin County, the numbers are all up. So as we've been talking along, some of this reflects increases in testing. And we particularly have been able to get in some testing in the areas that didn't have as much access before. And so you test more, you get more numbers, so that's expected. The other thing is that we really are really seeing now that those groups of people who weren't really able to shelter in place effectively over the month of April are disproportionately affected. And these include people who are from lower socioeconomic groups, and or racial and ethnic minorities as well. And the numbers there are usually found in clusters that are in clusters of families or of workplace clusters. So when you start talking to somebody, you find out they work in a place where there's been other cases, and then you go and you talk to their family members, and their family are also sick, and then everyone gets tested, and we find more positives. So that's kind of what's going on with our increasing numbers. Now, does that mean the whole community is affected? Not really. And in fact, information that we have about the community at large is that unless you're associated with one of these cluster groups, our numbers really aren't up that much. Now everyone has heard about the meatpacking plants. And cases in meatpacking plants, and here in North Carolina, we have not been immune to that. And several meatpacking plants in North Carolina, including up in Wilkesboro, the Tyson's plant, have been affected. And I think some of those outbreaks are becoming under control and under a little bit better understood. Still some work to do, but at least we're starting to understand them better. I really wanted to talk a little bit about testing. And it's kind of like when I teach my medical students and 30 or 40% of people get a question wrong on the exam, I'm going to come back and explain it to them again. So if you understand it, then that's fine, but otherwise I think it's worth going over again. There's really two types of tests that we use for testing for COVID, and I'm going to simplify it a little bit. One's a nose test where we go in real deep in the nose and get material, and the other's a blood test. Now, the one that we use for diagnosing acute infection, that means people who are sick, or who have been exposed and have the virus, is the nose test. And what we're looking for there is RNA, which is the blueprint that the virus uses to make itself and replicate. It's kind of the brains of the operation, so we're looking for the virus brains. The other test, the blood test, we're looking for antibodies, which is our body's response to the virus. One test measures whether the virus is there or not. That's the nose test. The blood test measures whether it's been there in the past and our body has seen it. So the nose test is not exactly always what people think it is. What it does is it tells you whether the virus is there in the nose. It doesn't necessarily tell you if somebody is sick from that virus or not. And like all tests, there are some pluses and minuses. So I want to go through what I consider the 5 big myths of the nose test testing. myth number one: if the test is positive, it's positive. If the test is negative, it's negative, and it's 100% all of the time. No test is that good. And sometimes tests will tell you that somebody has something when they don't, and sometimes tests will say that they don't have something when it's actually they do. So we always have to, as doctors, take that into mind when we're testing people. And what we do is we get the signs, the symptoms, do a physical exam, get some other laboratory data, and then we do the test and we interpret the test and the entire picture of the patient. And that's when these tests work the best. Myth number two is all of these tests are equal. That's not true. Some tests of these nose tests are more sensitive than others. And a report in the Washington Post this morning highlights that some of the extremely rapid tests that everyone's been touting and thinking is the fix-all for everything actually are much less sensitive and will have negative results sometimes when people actually have it. So here I happen to know the tests we use in our hospitals here in Forsyth County, and we've taken tests that are tried and true, have been looked at extensively, and I would say vetted, which means we've actually done them ourselves on known positives and negatives and found out their performance characteristics. And so these are the tests that I think we want to continue to use. If you're using or you've been used or somebody's tested you with that very, very rapid test, if it's negative and you still have signs and symptoms consistent, you probably should get a second test. It's kind of like when you get a strep test in the office and you're a kid and it's negative, we'll back that up with the culture. Same sort of thing. The third myth with these tests is one and done, which means, hey, I got tested, I'm negative. Good to go, right? No, not quite, because it just means that we didn't find virus at that particular time. It doesn't mean that you won't have virus in 3 or 4 days, and it won't mean that that you haven't technically been exposed. It just means you don't have virus in the back of your nose at that time. And so if you've been tested and you're negative, that doesn't mean you can let down your guard. That doesn't mean you can take the mask off. It doesn't mean you don't have to socially distance. You still have to do all those things, because if you're negative now and you could be exposed in 15 minutes and then get it then. So a negative test is not the end all for you. The fourth myth about testing is that if I've been exposed to somebody and that person is positive for COVID and I get tested negative, I don't have to quarantine. This is really, really, really important. If you are a contact of a person who is known to have COVID, a test does not get you out of quarantine. You're still going to watch Netflix for 10 days, or 14 days actually. Sorry, I misspoke on that one. 14 days if you've been in contact with somebody who's known to have COVID. And even if you go get tested, if the test is negative, you are still watching Netflix for 14 days at home. And the reason why is because the test we don't know exactly when the test becomes positive in the course of your 14 days. So if you get tested on day 2, it just may mean that the virus hasn't gotten itself ingrained enough for the test to be positive yet. Does that make sense for everybody? So if you have been exposed, a negative test does not get you out of quarantine. It's really important. You still have to quarantine. The last myth is that, if we could test everybody right now, COVID's over, we're done. And that's not true. If we could test everybody now and know their status, then we would put the positive people in isolation. We would put the contacts of those positive people in quarantine. And then we would have to continue to do that over an extended period of time. And then maybe if we could do that, we could really push down the amount of COVID in our areas. But the important thing there is not the test, it's the contact and the quarantine and the isolation. And unfortunately, I'm finding that not everybody who has been tested positive isolates, and not everybody who's been a contact quarantines. Some of those are for just reasons that are really hard to fix. You know, hey, I got to go to work. I got to feed my kids, or, you know, I feel great. Why can't I go to work? And they don't, you know, totally understand that quarantine is quarantine, and if you've been in contact, you have to do it. So testing is only as good as what we do with the results, right? Makes sense. So when we get out there and start testing more and more and more, people are going to have to be good citizens, and while they're waiting for their test result, isolate. If they're positive, stay isolated for 10 days. And if they're a contact of a positive, quarantine for a full 14 days. So the 5 myths of testing. Hopefully that wasn't too complicated, but testing sometimes can be complicated. Now the blood test just tells you whether or not have you been exposed. So far, blood testing in our area here in the Triad, we found that not a lot of people have been exposed. Probably no more than 2%. So good news is shelter in place worked. We didn't get exposed. The other side of the coin, though, is that if you're looking for immunity of a population, we have a long ways to go. We still don't have information as to whether a positive blood test says you actually really will be immune, and how strong that immunity is and for how long it is. So right now a blood test is best done for either public health research to understand a population, or for immunity research. And for any one particular patient, it's still really hard to interpret, and will be for a while. So that's what I have to say about testing. And I'll take your questions at the end if you have any on the testing situation. Oh, by the way, like I said, we are testing more. The capability in Forsyth and the Triad now to test people who have symptoms, I think, is very good. But what we'd like to do is test some populations of people who might have had higher risk of being exposed, and we're working on doing that. One other thing I want to caution people on, and it seems obvious, but getting yourself deliberately exposed to COVID is not a good idea. And I've seen some of this in the media, in other areas. I've seen questions come up on listservs, and that, you know, I've heard that the airlines aren't going to let you in unless you have a positive blood test and have been exposed in the past, or I've heard my workplace won't let me back in, or I've heard that if I haven't had it, I won't be able to do this or this or this. So I'm going to just go get myself exposed and be done with it. That is not a good idea. Now, even though for any one individual person being infected with COVID isn't an extremely high risk, for certain groups of people it is. And particularly for the elderly and for people who have underlying diseases. So if you've gotten yourself exposed and then you expose somebody else who's in that category, that's not good. And you've really impacted on somebody else's life, if not threatened it. The other thing is that even though it's unusual, there are young, healthy people who get COVID and who don't do well, including die. Not common, The percentage risk is low, but why submit yourself to any kind of risk at all when you don't have to? So let's not be doing that and getting yourself directly exposed. I think with that, I'll just go ahead and open it up for questions, because I know there probably are quite a few today.
I guess, so you talked about what we're seeing might be a lot of clusters, or maybe still not indicative of the amount of COVID in the community at large, of the new test. I guess that being said, the last 2 days, Forsyth County's made up an eighth of all new cases in the state. I was just wondering if you could kind of expand on that thought a little bit.
Yeah, so it was asked, what I had said is that a lot of our new cases are associated with clusters and maybe not indicative of the community at large. And I know that to be true for a couple of reasons. One is we have testing sites that are spread out over different areas, and our overall percent positive for people who have symptoms compatible with COVID is only 6%, which means that 94% of people who have flu-like illnesses or sore throats or stuffy noses have something else. But in certain areas and in certain testing sites, the percentage is much higher. And when we drill down with what those positive tests are, we can tell that they're associated with other known positive tests. The other thing is by looking at our hospitalizations. So our hospitalizations are up some in Forsyth County, not hugely, but up some from what they were 2 weeks ago. And then when you look and you talk to the people who've been hospitalized and look and what their risk factors and their individual risk factors are, we usually find them to be from these clusters. So that's why I say that. Yeah, our numbers are up. We've been focusing on trying to sort these clusters out better, and so that we can contain them. And that's one reason why the number of positive tests are up. Across the state at large, places like Mecklenburg County or Charlotte, which had really high numbers back in April, not as high as New York, but high. Their numbers are come down, but they're still having cases. Same thing with the Triad. The thing across the state that's a little bit different now than it was in April is that counties that didn't have hardly any activity, are less populated, more rural counties, are seeing it now too, and so it's spread into those areas as well. And we here in Forsyth and Guilford County, our hospitals are catchment areas for a lot of rural counties, so we see those cases here too.
With NASCAR being one of the first sports leagues to resume competition, do you see the upcoming races as a trial run or precedent for sports as a whole of their ability to restart?
The question is about NASCAR and whether I see that NASCAR being one of the first sports to get going again, whether this could be a bellwether maybe for other sports. Well, when you think about it, if you want to pick a sport where people can compete safely, NASCAR is probably one of them. I know their pit crews are it's kind of hard to socially and personally distant on a pit crew, but my understanding is that they're screening these people and testing them and looking at them before the race. So we'll see how it goes, and we're doing it without the fans in the crowd, right? And for NASCAR, so we'll see how it goes. I think there's other sports that could come up and probably be done safely as well, and most of these, it makes sense, non-contact sports. Gymnastics, competition swimming, things like that. and just to add on, you know, in the new our phase one for the quote opening of the state, or relaxing is the term I like to use, of the state. Day camps are okay per the governor, as long as the numbers are controlled and it's non-contact and people can personally distance. And if it's in a facility, the facility at large is not open to the public. It's just the campers, and you know, so that people can be screened. So there is a way to have some day camps within phase one for us in North Carolina. Good news for some parents, right? Yeah.
So with the mention of phase one, we're about, I guess tomorrow will be a week into it. Do you think we're ready to look at going to phase two?
Are we ready for phase two? The short answer is no, we're not. So going into phase one was kind of like, as I said last week, putting your toe in the water a little bit and seeing how it's going to go. And we've done that, and you know, a lot of the things that have opened up with phase one are things that are a lot more safer to do, and the increase in the cases that we've had with these clusters throughout the state and in our area in the last week or so is not because we relaxed last week. It's just not enough lag time. It takes about 3 weeks to really understand how that's going to go. If we can get a handle on these clusters, increase testing, and with it increase isolation and contact, which is the important part. Remember, it's not the test, it's what you do with it. And then maybe we can be ready for phase two towards the end of the month. That would be what I hope. But we'll have to see how it goes. If it stays like it is now, there's going to be a lot of things that are on the phase two list that we're not going to be able to do. Some of the things maybe, not everything is of the same level of risk on phase two. So, for instance, opening a al fresco restaurant with outside dining, opening up some of the wineries in the western part of our counties, where you can have, it's easy to outside to personally distance and do things. So some of that's probably might be okay, but opening up indoor fitness centers and areas where there's intimate contact, massages, and barber shops. Unfortunately, as I say, unfortunately, I probably still need my hair cut, but. So we'll have to see, but right now it's not looking like we're on the right path to opening up phase two. But we got a couple weeks yet to work on it, so.
With these, so really what you're saying is, with the opening up last week, if there's going to be any increase with that, it's still another week or two away.
Yes, because in order to see what the opening has really done for us, it's going to be a week or two away. And it won't be just looking at cases that are in these kind of defined clusters. It'll be looking at the level across the community at large, which right now is not widespread. But we have ways of looking for that through our hospitalizations, looking at influenza-like illness in our clinics, looking at absolute numbers, and then also parsing out where and the geography of where they are.
There's a growing segment of people, at least online there is, don't believe that coronavirus is real and that hospitals are receiving federal dollars to diagnose more patients with it than actually have it. Can you talk about that a little bit?
Yeah, I've seen that too. I've seen these reports. So the question is there's a growing number of people, particularly it seems like online, who think coronavirus isn't real and that hospitals are fudging the numbers for either political or money reasons. I can absolutely, with 100% certainty, tell you that it is absolutely false. I think it's probably an insult to all of the people in our hospitals who are in our ICUs and who are in our wards who clearly have it. And their families, I take it as an insult. I know that's a strong feeling, but it is absolutely false. We don't do that, that is just simply not the case. Coronavirus is real. It's a real threat, and if we don't take it seriously, it's going to win this rather than us, and we need to take it seriously. Those online comments are just not helpful.
I have another question. So there's an illness going around that could be linked to coronavirus called pediatric multisystem inflammatory syndrome.
Yeah.
Do you know of any in the Triad, or can you talk to that a little bit?
Yeah, so I'm going to simplify the question is what about this illness in kids, the pediatric inflammatory syndromes, and it's probably more than one that is being lumped together, but they all have something in common, that it's kids that have been infected with coronavirus, and then who then developed what looks like something we call Kawasaki syndrome, which is something we've known about in kids almost since the beginning of time, and it's an inflammatory response probably to infection. In this case, it's coronavirus. It's unusual, it's rare. I know of no cases here in the Triad. Now, it doesn't mean that I have 100% knowledge of every case in the Triad, but I don't think we've had any here. If you look at the numbers from other states, in a place like here, like in North Carolina, you would only expect maybe 20 to 50 cases over the entire state in everybody, so it's not a real common syndrome. And while it's a serious syndrome for children, there are treatments for the inflammation that go with it. So, and I'm going to use that question as a stepping stone, that we've seen a lot of kind of interesting things with coronavirus infections that we didn't expect. So this is a virus that scientifically is interesting, but medically is kind of annoying for us. One is blood clotting, in that people who get serious coronavirus infections in particular have an increased propensity for blood clots that can cause blood clots going to the lung, or blood clots going to the brain, which is a stroke, or occasionally to the heart, which are heart attacks. And so we've learned a lot about that over the last month, and we're starting to learn how to use blood thinners and when to use them for people to try to reduce this propensity for blood clotting. The other syndrome is rashes, kind of funny rashes that you see, one of which is called COVID toes, which is when you get rashes on your toes. And to the people who have it, it's a little bit like a burning sunburn, and then you look on the toes and there's clearly a rash on it. These people, for some reason, tend to do very well overall with their COVID infection. Their symptoms tend to only last 2 or 3 days. They don't get seriously ill. They're very rarely hospitalized. So if you want to get COVID toes, because it's less serious than the others. We're seeing a lot of kidney failure in people who have severe COVID infections. And this has to do with the body's inflammatory response towards the virus. And we're also seeing something called myocarditis, which is an inflammation of the heart in people who have serious COVID infections. So there's kind of all these little sub-syndromes in COVID that we're learning more about. The good part about it is as we learn more about those, we can approach those individually and help people so that the overall survival for COVID, we anticipate, will improve as we learn more how to deal with these complications. And I think it is already, to tell you the truth. Now, when I say that, let's go back. Remember, way at the beginning when we first started talking about COVID, I said 85% of people have mild to moderate COVID, stay home, and get over it, and usually in 5 to 6 days. And that's 85%. That's still a pretty good number, so for any one particular person, they can be reassured. About 10% of people will get hospitalized in a regular hospital bed and need oxygen. And about 5% of people end up in an intensive care unit with their COVID and have more serious infection. That hasn't changed from the beginning to now. Those numbers have been lock solid. That hasn't changed. And also what hasn't changed are the people who are more likely to have more serious infection, and it's still people over the age of 60 to 65. It's still people with underlying illnesses. But one that we've kind of learned about in the past month is being obese, particularly with something we call a body mass index over 40, which is a number. It increases your risk also, including even in kids. So obese children have a higher risk than non-obese children.
So you were talking about the inflammatory syndrome in children. Are you concerned? You said it didn't seem like there had been that many cases in North Carolina. Are you concerned that could be a problem, and would that affect the opening of schools?
Yeah, well, so the inflammatory condition in children that sometimes is associated with COVID, and they said, well, I didn't seem that concerned about it for numbers in North Carolina. I mean, you know, for any one particular person, obviously I'm concerned. I mean, any complication, particularly in a child, is something we don't want to see. But it's not a large number of children. So will it affect the opening of schools? The opening of schools it's not only about the kids, but it's also about the staff and the other people who come into the schools and everything that goes into having a school open that we have to figure out. We've known from the beginning that children sometimes do get COVID, and while the vast majority of them do great, in fact, only I think 1% to 2% of the people in North Carolina who've been tested have been children under the age of 17. So it doesn't affect them as much, and when they do get it, it still is usually a very mild infection. But every now and then, this little inflammatory syndrome gets triggered off in a child. And there are other viruses that can trigger that as well. We don't understand those as well, but even something that's like flu or another virus. So it's not just COVID. But right now, COVID's is ruling the block, right, for viral infections. So that's the one where we see it triggering. I don't think that one particular syndrome will affect our opening of schools. There's a lot of other factors to consider for school openings.
As far as playgrounds and other gatherings?
Playgrounds, football teams, football games, staff, teachers, personally distancing. You know, our schools are already a bit crowded. How do you personally distance in a crowded schools? So the school systems and our education system have some tough questions, but they got a little bit of time to work it out. So I know California just said, you know, basically we're not going to open schools. We're going to do it differently. That may have been a little bit of an overreaction. We'll see how the summer goes. How concerned am I about a second round of COVID-19? Well, I think there's probably a pretty good chance we're going to have a second round of COVID-19, considering we're not totally out of round one yet. But a second round is a distinct possibility. I would say it's more likely than not that we'll see one. Concerned about it from the standpoint that, hey, we won't get through it, or, you know, it'll be a game stopper or something. That I'm not concerned about. You know, I think we'll find a way to get through it when a second wave happens. It might be really annoying that we might have to go back to, you know, being locked down again or take other measures. We'll see as it comes around. But we've learned a lot from round one. So at least and hopefully by round two, maybe we'll have some other tools. There's a lot of drugs being looked at potentially for treatment of COVID right now. Everyone's heard about remdesivir. Remdesivir is the one that became famous, so to speak, a couple weeks ago in the national news because we had a trial that said that people got better faster. Maybe not necessarily the overall outcome was much different, but the people who got better faster. So that drug is now becoming available to us here in North Carolina. And I think you've probably seen some press releases on that out of Raleigh, including here in the Triad. We have a small number of doses, but which we hope to increase the number. By far and away, we don't have enough to treat everyone with it, but we're picking the people who we think would benefit the best and most from it. There will be other drugs coming out, I think, that potentially would have treatment. Like any antiviral is a treatment, you know, a magic wand cure. Hey, wave the drug and it's gone. No, but hopefully it'll reduce morbidity, it'll reduce mortality with the new drugs coming out. The other thing is that, as I mentioned earlier, we're learning about other treatments that might influence complications for COVID, such as blood thinners, other anti-inflammatory approaches to reduces the body's extreme response to this virus that is what's making some people really sick. So.
You know, you were talking about the if there is another round 2, we haven't got, of course, we haven't got through round 1. If there's a little bit of lull this summer, and people are able to get out and things get back a little bit more than normal, I guess the big thing would be to prepare in case there is one. I mean, what would just a general person do as far as?
Yeah, well, what can a general, right. So I think the question, if I synopse it right, is what can a general person, or what can a person do to generally be ready for a wave 2 should it come? We made it through wave 1. We're still making it through wave 1. So whatever you're doing now that seems to be working for you is something you could do through wave 2 as well. I think that you know, a lot of things that we've learned how to do successfully during wave 1 would become just as good of a tool during wave 2. Working from home, limiting travel, personally distancing, and learning how to do all that in a safe way. So as we get into wave 2, when you have to do those essential things like go get your groceries, now we're doing it with masks, now we're doing it with personal distancing, reducing the number of people in stores. That's going to help. So that's going to be something that's going to help us get through wave 2. And then part of it's just getting your mind set, you know, that it's something we're going to have with us for a while. And they're going to be, just like at the beach, when you get a big wave that almost knocks you down, there's a few small waves that come after that. There may be another big wave out there, but you know, each time we get back up and we stand up, and we learn how to take on the first wave. Makes taking on the second wave a little easier. So I don't think people have to be scared of it. It's just something that we're just going to have to get through. There will be an end to this one way or another. The virus will eventually meld its way into just becoming another one of our respiratory viruses that we have. I do think we'll eventually have a vaccine. I personally think that we'll have a vaccine that works, and that's going to be something that's going to really help us get through all this. So this is not the way it is going to be forever. Just like they learned from 1917 and 18 with the Spanish flu, you know, that virus is still around. People don't even realize it. It's just something that we deal with and work with now. We have treatments for it. We know how to vaccinate people for it, and we've learned to live with it. So, I just also want to make sure that people understand that, you know, as we get into the summer, things that we're doing now with masking and personally distancing, limiting large gatherings, being smart about what we're doing is still going to be important. But let's use our ingenuity and figure some things out so that we can have some joy and get out and do some things that are still fun. And the number one thing is outdoors. Anything done outdoors is better than doing it indoors. Yoga outdoors better than yoga indoors. Jogging better outdoors than in indoors. Eating better outdoors than in indoors. Picnics, so on and so forth. I don't want to bore people with the details, but it's and that's the way I think for the next year we're going to still be able to do things that we enjoy and have fun with their families. Even though it may be harder to travel, Disney World may not be open for a while anyway, things like that, but there's still a lot of enjoyment we can have with our friends and family. Phase 1, what we're in right now, it's okay to have backyard cookouts with your friends. Up to 10 people, socially, personally distance. Be smart about it. So it's okay to do things like that, and will remain so, I think. Oh, I was asked to show people something, and it has to do with how to wear a mask. And again, if I'm insulting people's intelligence, I'm sorry. But a mask like this is not a complete mask because your nose isn't covered. So you have to get it up and make sure it's on and around your nose. And if it's a little annoying, pulling it down and doing this doesn't work. You have to cover both the nose and the mouth. And that's really particularly important when we're inside, particularly when personal distancing is as important. If you're on a real crowded greenway and there's a lot of people around, you can wear it down. But otherwise, outdoors, like what I'm doing now, you guys are more than 10 feet away from me. And so probably don't need it right now. But when you're using it, make sure you use it right. Any other questions? Good. All right.